Assalamu alaikum. Good afternoon, everyone. It's Betty. Today topics, we will be talking, inshallah, about developmental anatomy and then anatomy and classification of for congenital cardiac disease. Our guest consultant is going to be Dr. Ibrahim Abdullah. He's a consultant congenital cardiac surgeon working in King Faisal Specialist Hospital. There's a change in the schedule. We will first begin with the anatomy and classification of congenital cardiac surgery, then developmental anatomy. Are my slides clear?
Yes.
Yeah, they're clear.
Excellent. Okay, so the topic is going to be segmental classification for congenital heart surgery. I'm sorry, just one last question. Is it enlarged or do you see the...
الوليد سوي full view. We can see the notes and the next slide on the side.
Okay, better?
Yeah, it's better.
Great.
Okay, so let's begin. So the topic is segmental classification for congenital heart surgery. Classification in congenital heart surgery is important not only for malformed hearts, even for this classification system will work even for morphologically normal hearts. Obviously, it's a skill that is very important for every cardiac surgeon, especially those who choose to specialize in congenital cardiac surgery. In the past, there has been a lot of attempts to classify the different chambers of the heart. And over the years, it has been developed depending on the issues and the arguments that were raised against prior systems. Nowadays, the logical or the system that still we have some controversies within these newer systems. However, the controversies are much, much better than it used to. Nowadays, if you look into every textbook for cardiac surgery or every source, you'll find them talking about the sequential segmental analysis for heart chambers. This system has been developed for an issue that was faced by people who used to categorize hearts, as sometimes it was difficult to define, for example, a right atrium from left atrium, because of the ways that we used to define these chambers. Now, within this system, there are some principles that we would need to stick to in order to successfully and correctly define or categorize each chamber. One idea or one principle is using morphology, or morphological principle or method. Basically, this method relies on establishing a consistent feature that is found in whatever segment that you're trying to identify. For example, in the past, if you were to define the left ventricle as the ventricle that has the mitral valve, obviously you'll start to run into issues when you have, for example, mitral atresia, as you will not find the mitral valve and you'll not be able to identify the left ventricle. Similarly, for example, if you were trying to differentiate the left atrium from the right atrium by, let's say, the pulmonary venous return, so we know now that in some hearts, there is anomalous venous return, even to the hepatic venous system. And that will lead to a scenario where you'd say, for example, due to the venous return going to the liver is the morphological left atrium, which obviously does not make any sense. So the this idea of using morphology to define a chamfer also relies on another principle, which is emphasized, that the segment should not be used, that a segment should not be used to define another segment, or a structure that is variable should not be used to define a segment. As the previous example, the pulmonary venous return is a variable structure, so it cannot be used to define a left atrium. Now, when we look into the heart, obviously now throughout the presentation, we'll be talking about the segments and the morphology of each segment and which features that are consistent across each segment. Now, let's begin by establishing the segments that we will be talking about. So we have, in general, 3 segments and 2 connections. The segments that will be discussed, the first segment is the atrium, the ventricular mass, then the arterial trunks. Now, between each of these 3 segments, there's a connection. So between the atrium and the ventricle is the atrioventricular connection. Between the ventricle and the arterial is the ventriculo-arterial connection. Now, when we define or when we classify the heart, we need to know that each segment and each connection is completely independent in itself from the other segments. So we cannot rely on the morphology of the ventricles, we cannot rely on the arrangement of the ventricles to define the arteries. Similarly, across each of these segments. Now, in our system, as mentioned before, we'll use sequential segmental analysis. So obviously, we'll go by order. So we'll try to identify the atrium, then the atrioventricular connections, ventricle, ventricular arterial, and then lastly, arterial trunks. So we started this presentation by saying that we need to find a consistent feature. Obviously, the arrangement of the atrium, it consists of body appendage and vestibule, or the outlet for the atrium. Now, out of all the features of both atria, the most consistent feature that has been found is the atrial appendage. Now, both atriums both atria have obviously many characteristics. For example, in the morphological right atrium, the shape is blunted. It's a blunted triangle. It has a broad junction with the remainder of the atrium. The junction is marked externally by terminal groove and internally by terminal crest. And the pectinate muscle lining the appendage extend around the AV junction. I'll bring gross pictures later on. On the other side, the morphological left atrium, the shape is more tubular. The junction to the body is much more narrower than that of the right atrium, and the junction is not marked by terminal groove or terminal crest. And more importantly, among all of these differentiating factors, the most important for us to identify which one is the morphological left or right is the pectinate muscle extension. So in the left atrium, it's only lining the appendage, inside the appendage. It's confined within the appendage, and the remainder of the body is smooth. Contrast that to the right atrium, where the pectinate muscle lines, it extends across the AV junction. Here we can see on the left side of the screen, we can see the right atrium, and we can see the pectinate muscle lining all the AV, lining across the AV valve, compared to the left atrium, where it's hardly visible. However, this is the appendage, and as we mentioned before, the pectinate muscles would be found inside the appendage, and the remainder of the atrium is smooth. These are further gross illustrations showing the same thing. These are gross illustrations showing the shape of both atriums that we discussed before. Here we can see the right atrium. There's another photo of the right atrium. It's very broad, and the shape is triangular, compared to the left atrium appendage, which is tubular and much narrower than that of the right atrium. Here's another much clearer illustration of that. Now, after identifying the atrium, now we can classify it or try to find some sense into its arrangement. since we have two morphological atriums, that can create four possibilities or four outcomes. Either the first outcome, which is the usual one, or what is termed sinus situs solitus, yeah, situs solitus, which is the usual arrangement of the atriums, where the right morphologically right atrium is found on the right side, and the morphological left atrium is found on the left side. Now, when you reverse that, you have what is termed situs inversus, or the mirror image of that. Other arrangement is basically right isomerism or left isomerism. In some classifications, it's called ambiguous arrangement. That's when you find one of the morphologies, whether be it right or left, being the dominant morphology. So in both sides, you'll only find morphological right atrium or morphological left atrium. Now, all of this can be seen during OR when you open the atrium, or nowadays with the development of the echo, that's possible. Can you, however, clinically infer the arrangement of the atrium using other organs or any form of clinical examination? Yes, but it's not as consistent as the actual atrium themselves. You can use the abdominal viscera or the thoracic viscera. The thoracic viscera is much more consistent and much more in harmony with the arrangement of the atriums. However, and when the atriums are lateralized, the term lateralized means that we have a left and morphological left and morphological right. When that's the case, such as in situs solitus or inversus, you'll find the liver being on the right side, and we have tri-lobes of the lung in cases when there's the morphological right atrium on the right side. The mirror image of that is going to be the case in situs inversus. Now, when you have ambiguous atriums or right isomerism or left isomerism, usually the abdominal viscera is jumbled up, basically. It's very difficult to define the morphology of the atriums. There are sometimes with left isomerism, you'll have multiple spleens, and the spleen is going to be absent in right isomerism, but that's not really consistent. However, what was found that the thoracic viscera or organs are usually consistent with the morphology of the atrium. Now, if you would look to the bronchus, the morphological left bronchus is usually long. And the pattern of the artery in relation to the bronchus is termed arterial. What do we mean by that? That the bronchus only branches after it's crossed by the artery. This is called arterial. On the other side, the right morphological bronchus is usually short, and it's crossed by the artery prior to branching. And this form is usually called arterial. Now, if you'd look to in situs solitus, for example, when it's normal, you'll find the right morphological bronchus on the right side, and the opposite is true. Now, when you inverse it, or the mirror image of that in situs inversus, you'll find it reversed. Now, why did we mention all of this? It's mainly because of the right isomerism and left isomerism. And right isomerism, obviously, you'll have arterial branching of both bronchi, and on the other side, you'll have arterial arrangement in left isomerism. Now, other inferences can be obtained. It's not only the thoracic organs. Also, you can get a hint of the arrangement of the atrium using the abdominal great vasculature, namely the aorta and the IVC, and their relation to the spine. When you have a lateralization of the atrium, as we mentioned before, where you have both morphological right and left atriums, the aorta and the IVC are on opposite sides of the spine. And the IVC is on the side of the morphological right. Now, when you have isomerization of the atrium, the aorta and IVC are on the same side of the spine, and the IVC being anterior in cases of right isomerism or posterior in cases of left isomerism. Sometimes when you have interrupted IVC, you'll have a posterior azygous vein. This is an illustration of what we mentioned before. When you have usual arrangement of the abdominal organ, you'll have the IVC on the right side, IVC and aorta on opposite sides of the spine, with the IVC being anterior, and it's on the right side, which is the side of the right atrium. Mirror image is illustrating the same, with the IVC being on the left side. Now, in right isomerism, we said the IVC, both in cases of isomerism, regardless, both aorta and IVC are on the same sides of the spine, with the IVC being anterior in cases of right isomerism, and we have azygous posterior to the aorta in cases of left isomerism. So now we're done with the atrial arrangement or classification of the atrium. This is an image illustrating all of what we mentioned before, all four possible arrangement of the atrium and with possible arrangement of the remainder of the organs. Now, we move to the atrioventricular junctions. To analyze the morphology of the AV junction, we need to know the atrial arrangement and the morphology of the ventricular mass. This is important because basically we're trying to identify the way that the atrium is connecting to the ventricular mass. In majority of the hearts, there's a possibility of having two atrioventricular connections. However, this possibility is not always fulfilled because one of the connections may be absent. These two, basically knowing that we have three possible outcomes or three groups of for the possibilities of the connections between the atrium and ventricle. The first group is when we have each atrium that is joined separately to an underlying ventricle. The second group, only one ventricle is connected to both atria, whether through one or two connections. The third is when you have one AV connection that is absent, and the other AV connection is connected to two ventricles. Now we'll discuss each in more specifications. So the first group is the group that we said each atria is connected to a ventricle separately. So within this group, there is three possible arrangements. So each atrium can be connected to its morphological appropriate ventricle. So whatever the place of that, whatever the side of that atria. For example, in this first illustration, we can see the right morphological atrium connected to the right morphological ventricle, and the opposite is the case as well. Even in the mirror image, the right morphological atrium, even if it's in the left side, it's connected to the right morphological ventricle. This form of arrangement is usually termed concordant connection, because each, morphologically speaking, each atrium is connected to its appropriate ventricle, whatever the side is. Now, the other case, when you have a right atrium, morphological right atrium connected to morphological left ventricle, and the opposite as well, this form of arrangement is termed discordant connection, whether be it usual atrial arrangement or atrial arrangement. Now, the third case is when you have mixed connection. That's when you have either isomeric basically right isomerism or left isomerism, and they are connected to whatever form of arrangement of the ventricles. So this is the first group. This is the group that each atria is connected to a ventricle. The second group that we mentioned is one ventricle is connected to the both atria. As well, this has three possible arrangements. So either that both atria are connected to the same ventricle. This creates what is called double inlet AV connection. The two possible scenarios is when you have one of the AV connection absent and the other one is present and it's connected to a ventricle. whether that can be the present AV connection can be left-sided or right-sided. So this might seem scary at first, but ignore the first and the last row. This is what we just spoke about. We can have one arrangement where the two atria are connected to one ventricle. In this case, it looks like the left-sided ventricle. In here, we have absent right-sided AV connection with both atria connected through an ASD to one side of one ventricle. And here, the left is absent and the right is connected to one ventricle. Okay, now going back to the first and second draw, as we mentioned before, that each segment, each connection is completely independent in itself from the rest of the heart. So we can have whatever arrangement of atria, whatever arrangement of ventricle, and we can have the same exact forms or types of connection. So we can have, for example, right isomerism of the atria. Both have AV connections that are connected to, for example, right or dominant RV or dominant LV. Now, okay, so now we finished with the AV connection. The AV connection that we said, it's basically the way that the atrial musculature is joined to the ventricular mass. That doesn't say anything regarding the valves that are guarding these AV connections. Obviously, when you're trying to classify or analyze the heart, you'd need to comment on the valves of the AV connection. The valves can be either you can have two patent valves and two AV connections. You can have one patent and one imperforate, or you can have one common valve. Now, with the introduction of valves into this whole analysis, there are terms that you need to be aware of when you try to describe valves. Valves can straddle and they can override. So what's the difference between the two terms? Straddling means that the tension apparatus of the valve is attached to both sides of the septum. So again, the straddling is basically having the tension apparatus, or basically the babilla, or the papillary muscles and the chordae attached to both sides of the septum. Overriding, the valve overrides when the AV connection is connected to ventricles on both sides of septal structure. Basically, meaning that if you would look to the valve from above, you'll be able to see the septum crossing within the valve. IV valves can straddle, they can override, and they can do both. Here's an example of these terms that we discussed. So let's look at the right-sided valve in this first illustration. We can see that part of the valve is located slightly to the right of the septum. This is called overriding. So this right-sided valve is overriding the septum. Now, if we look at its tension apparatus, namely the chordae, we can see it being attached to the other side of the septum. This is called straddling. So that's that for this explanation of these two terms. One more thing that you need to know in cases of overriding, when there is a valve that overrides a septum, this creates a scenario where you need to further describe the valve because the presence of overriding influences its description. So if you have an override with a degree, for example, in this case, let's look at this left illustration. The right-sided valve, it's overriding the septum. However, the degree of override is less than 50%. Let's give it 25, for example. This makes this valve committed to these two chambers. So this creates a scenario where we have a first group where the atria, each atria is connected to each ventricle. Now, when we look on the other side, we can see there's also some sort of override of the right-sided AV valve. However, the majority of the valve is committed beyond the septum to the other ventricle. In this case, this valve is committed to this ventricle, and we term this double inlet AV connection with double inlet to this morphological, looks like a right ventricle. I hope that this is clear. Please do stop me whenever there is any question. Now, there's just this point regarding calling a valve mitral or tricuspid. This usually works when you have biventricular AV connection, with each connection having separate junction that is guarded by its own valve. Usually the tricuspid valve is the inlet valve for the morphological right ventricle, and the mitral valve is the inlet valve to the morphological left ventricle. Now, when you have cases, for example, when you have absent right-sided AV or tricuspid atresia, sometimes you can infer based on the morphology of the other valve, which is the mitral, that this is a mitral valve because it's connected to the LV, and you can call this tricuspid atresia with mitral valve connected to the mitral. However, to avoid confusion, it's better if these AV valves are termed right-sided or left-sided AV valves. This is especially the case when we're dealing with AVST. Now we're done with the atria and the AV connection. Now we get to the ventricular mass. To identify the ventricles, regardless of how malformed they are, whether they are hypoplastic, complete, or not, you can analyze them as having inlet, apical trabecular component, or outlet. Out of these three components, the most consistent and usually present in normal or whatever form of ventricle is the apical trabecular component. Specifically, the pattern of the trabeculation that can tell you which ventricle we are seeing. In cases of morphological right ventricle, we can see coarse trabeculation. In the morphological left ventricle, we can see fine trabeculation with cross-crossing. These are illustrations showing what we just spoke about. You can see here that the trabecular component is very coarse when we compare it to the other side. This is very fine and it's cross-crossing. So we can tell, or we can infer, that this is a right ventricle and this is a left ventricle. Similarly, on the right side, same thing. These trabeculations are much more coarser than these of this other chamber. This is the right and this is the left. Now, further classification of the ventricle. Now, after we identified which one is the RV, morphological RV, and which one is the morphological LV, we need to talk about the topology or the looping of the ventricle, which is basically the relationship of the inlet and outlet in relation to the apical trabeculation. The topology is usually determined based on the morphological right ventricle. So we have two possible patterns. If we take the RV, and if you were to put your hands inside the septum of the RV, you can have two patterns. Either your thumb is going to be in the inlet and fingers in the outlet, or the other way around, where you have your thumb in the inlet and the fingers in the outlet. This first arrangement, where you have your right hand fitting this description, this is termed D-looping or D-topology, or right-hand topology. So if we look at this illustration, we can see that the thumb of the right hand is fitting into the inlet. That's termed right-handed topology. Let's say, for example, that the RV was on the left side. The morphological RV was on the left side of the human body. We will not be able to fit our right hand inside the inlet. We will be able to fit our left hand inside of that. This is termed left-handed topology. So in order to decide the topology, you'd use the RV. However, just one thing that you need to know. If you're using the RV, let's say that the right ventricle, morphological right ventricle, is on the right side. This obviously fits the right-handed topology because you can fit your right hand there. If you look at the left ventricle that is on the left side, you can fit your left hand. But we don't call that left-handed topology, right? Because what we're using to define the topology is the right ventricle, the morphological right ventricle. Just wanted you to know that because sometimes you can infer the topology using the left ventricle instead of the right ventricle. For example, in a left, if you can fit your left hand inside the left ventricle, the morphological left ventricle, basically this gives you a right-handed topology. I hope this is clear. Okay, so identification of the ventricle. Now, sometimes you have one single ventricle. This is extremely rare to have one solitary ventricle. Usually, there's another ventricle, but that is very small. Now, when you have one solitary ventricle, it has its own trabecular pattern. Usually the apical component in solitary ventricles, it doesn't fit the description of the left or the right. It's usually very coarse and crossed. Usually the isolated or the solitary ventricle is termed indeterminate morphology. Now, after we identify the ventricle, then we come to the ventricular-arterial connection. But before that, I wanted to discuss the great arteries. So how would we usually identify the great arteries? Within the great arteries themselves, there is no intrinsic feature that can be used to distinguish between each of the great arteries. However, their branching patterns usually can tell you. It's a good enough characteristic to define which is which. We have so the great arteries, we have the aorta, we have the pulmonary trunk, or we can have them both combined. So what are the specific characteristics to each of these four possible outcomes of great arteries? The aorta usually gives rise to at least one coronary artery, and it gives rise to the bulk of the systemic arteries. The pulmonary trunk, it gives rise to one of the two or more of the pulmonary arteries. Now, this is all clear. Now, when we come to the common arterial trunk or the solitary arterial trunk, what is the difference between the two? The common arterial trunk, it supplies the coronary artery, systemic vasculature, and the pulmonary arteries. And usually these pulmonary arteries are found intra-pericardial, so inside the pericardial cavity. And the other way around, where it's solitary arterial trunk, it has the same component. However, the pulmonary trunk is not found within the pericardial cavity. So in this case, it's termed solitary arterial trunk, and the other way around, and the other one is common arterial trunk. Now back to the connection between these great arteries and the ventricle or the ventricular mass. When you look at the ventricular arterial junction or connection, you can comment on the origin of the artery, the morphology of the infundibulum, and the relationship of these arteries to each other. So we'll discuss each one of these. If you look at the origin of the ventricular origin of the arteries within this ventricular arterial connection, you have four types of origins. You can have concordant ventricular arterial connection, discordant ventricular arterial connection. These two terms should be easy now after we discuss the AV ventricle connection. So we can tell that the concordant is when you have the aorta coming from the morphological left ventricle, whatever side that ventricle is on. The discordant ventricular arterial connection is when you have the aorta, for example, coming out of the morphological right ventricle, whatever that right ventricle is on, whether it be the right side or the left side. Different origins is when you have double outlet ventricular arterial connection, so both great arteries coming from one ventricle, and single outlet when you have a common trunk or solitary trunk. Other possibility is when you have single pulmonary trunk with aortic atresia, or the other way around. This is an illustration. You can see a lot of things here. I brought it to just point out one thing. So here we can see the aorta coming from the morphological left ventricle. So we can term this ventricular arterial concordance. The other way, you can see the aorta coming from the morphological right ventricle, and the pulmonary trunk coming from the morphological left ventricle. This is discordance. And here we can see double outlet right ventricle. Okay, so as we said, ventricular arterial junctions, there are three components that we need to discuss. The first is the origin of the arteries. The second is the arterial relationship to each other. Usually these are described at the valvular level or the semilunar valve levels. Usually it's best described as in terms of left or right and anterior to posterior. With that in mind, this creates a scenario where you have 8 possible outcomes, which we will discuss separately. The trunks themselves, they can be either parallel or the pulmonary trunk can spiral around the aorta. So these are the possible 8 outcomes. If you basically take any of these terms and put them with each other, you'll have these outcomes of aorta in relation to the main pulmonary artery. And you need to remember that as we discussed further, that all of these are independent of the morphology of the ventricle or the arteries in themselves. So lastly, the implantability region. It's basically the outlet component of the ventricular mass. We can have 4 possible arrangements. Usually in normal hearts, we have fibrous continuity between the aorta and the mitral valve, with the right side of the infundibulum being complete, muscular infundibulum. You can have the other way around, where you have complete subaortic infundibulum with continuity between the pulmonary and the right-sided AV valve, for example, or whatever actually. We can have 2 infundibulum that are complete. Basically, there is no continuity. Or you can have bilateral infundibulum with continuity, fibrous continuity between the arterial and their AV valves. Now, these are terms used in a classification called Van Bragg classification. Basically, we discussed all of these. We just need to review the terms. Obviously, in the atria, we already spoke that you can have solitous, inversus, or ambiguous. Ambiguous usually in cases of isomerism, whether left or right. In the ventricle, we need to look at the looping, whether it's D loop or L loop. One thing to note that this looping that relies on the right ventricle, it's irrelevant of where the ventricle is in space or side. So if you would to find the morphological right ventricle, it's whether it's a dextrocardia, it's a levocardia, if it's in the right of the ventricle, the morphological right ventricle is in the right side or the left side, this identification using your hand works. Lastly, when you look at the great arteries, solitous, normal, and inversus refers to if the aorta is coming from, usually if it's within their normal arrangement. So if it's normal, you call it, you give it the letter S, and opposite is I. Now, if you have the aorta in the left side, on the right side of the pulmonary artery, this is called D malposition or DTGA. If it's on the left side, this is LTGA. If it's anterior to it, this is A. Now, you can give a letter to each of these components depending on the arrangement that we already discussed, and you can have multiple arrangements. So, for example, in this normally arranged heart, we can look at the atria. This is situs solitus. So, because of the right atrium is found in the right side. So this is S. When we look at the right ventricle versus the left ventricle, the right ventricle is found on the right side, so it should have the D topology or D looping. So we give it D. The aorta is coming from the left ventricle. The pulmonary is coming from the RV, and usually these are in usual arrangements. So this is termed or given the letter S. And according to the morphology, obviously you'll give it different letters. Now, it's very important that to note that these letters do not give you any information regarding the AV connection or the ventricular arterial connection. So what do we mean by that? You can have, for example, if in the TGAL, what does that mean? As we mentioned before, that the aorta is coming to the left side of the pulmonary. That can occur when you have LTGA, or it can also happen in cases where you have double outlet RV. So as we mentioned, these letters do not give you an idea of the connections between the different segments. So that's that for the presentation. These are the references used in the presentation. Thank you very much. If you have any question, please feel free to ask me or ask Dr. Ibrahim Abdallah. If you have any feedback, please do share it.
Thank you very much, Waleed. Very nice presentation. It shows a very well understanding of the topic, and well done. Thank you.
Thank you, Edgar. Dr. Abdallah, do you have any comments or regarding the topic?
Yes, Waleed. Hello, can you hear me?
Yes.
Yes, excellent presentation. There's certainly a lot that was covered in the period of time, and this topic is, especially in the congenital realm, can be a pretty extensive discussion and sorry, I'm near the ORs because I got called. So if there's a bit of noise, you guys can let me know. I'll try to get to a more quiet location. But yes, I think the important thing, as you've specified, from the educational standpoint, is that in congenital as well as in the adult realm, essentially becomes a subset of sort of the possibilities, meaning the normal type of anatomic and morphologic and arrangement possibilities. But if you look at the general world, we have to basically understand in some systematic way what we are dealing with. And the key things that I think that the residents should take away is that whenever in the congenital world, whenever someone is saying left ventricle or right ventricle, what they're essentially saying is morphologic left ventricle and morphologic right ventricle. Is basically that ventricle, they say left ventricle, it's that ventricle, no matter where it is in space, that looks like a typical morphologic LV, meaning the sort of ipsiloid shape, the fact that the papillaries do not insert into the septum, the fact that the septum is a bit smooth and not as trabeculated as the right ventricle. So I think that's one key thing. The other key thing is sidedness. So when we say left-sided ventricle, we mean it's that ventricle which is on the left side of the axis. And that could be either a morphologic right ventricle or a morphologic left ventricle. So those are very key concepts. I think they're important ones as you rotate through the congenital realm and try to understand the various anatomies that come through. And then the other thing that you will also find is that what makes the description of the segmental anatomy more complete is how the atria and the ventricle are connected to each other, and how the ventricles and the great arteries are connected to each other, just like you had shown. So whether there's concordance or discordance, whenever you see the term transposition of the great arteries, okay, whenever you see that, that essentially immediately implies that there's ventriculo-arterial discordance. And again, it doesn't matter where those ventricles, those morphologic ventricles are in space, or where those great arteries are in space. But the connection between the morphologic ventricles and the great arteries, based on their branching patterns, that's discordant. Whenever you see the term TGA, or transposition of great arteries, attached to a diagnosis. But very well presented. Any questions from the group?
Thank you, Walid. Thank you, Dr. Ibrahim.
Welcome.
I don't think there are any more questions. So inshallah, we'll take a break of 10 minutes, then we'll return to the second presentation presented by Dr. Asad Bait, Developmental Anatomy.
Thank you.
Dr. Walid,
هلا دكتور.
we can start.
Yes.
طيب السلام عليكم. Good afternoon, everyone. Today, inshallah, we're gonna talk about the developmental anatomy of the heart. So, in order to do this, these are our objectives. And in order to do first, we're gonna do that in sections. First is the heart tube, our single heart tube, and the surrounding of the heart tube, what's called the pericardium or the pericardial cavity. And then we will talk about the septum or septation of the heart. And as introduction, human heart start to develop during the 3rd week of embryonic life. Until then, the needs of the embryo are met through the simple diffusion between the germ layers. And the cardiogenesis, the process of the heart formation, it's a complex morphogenic or morphogenetic event. So in order to do first, we have to start with this diagram, then going into the two-folding process of the heart tube. The first thing is that looking at the top of this embryo, when you look at the top or superior of the embryo, you will see two portions. This portion is simply the cranial aspect of the developing embryo, and this portion down here is the caudal aspect. And if you remember, during the gastrulation process, cells from the epiblast are moving down through the primitive streak and forming a new layer called mesoderm. This mesoderm is between the ectoderm and endoderm. What I want you to understand from this is that the collection of mesoderm is going to take place at the cranial aspect of this embryo. And you're going to have this in front of the precaudal plate. So technically, the heart develops in the head of the embryo and starts to move down to the thorax, as you can see in this 3D animation of the embryo. Now we look at this figure in two views. We're gonna take like this, and we're gonna look at here, this cross-section view, and the next thing we're gonna look from a sagittal section. When you look at the cross-section, after gastrulation has occurred, we will have 3 layers. This ectoderm, this layer is mesoderm, and this layer in the bottom is the endoderm. Particularly, the mesoderm is the layer we want to focus. This is from side view. When you look at the 3 components of it, this is called the paraaxial mesoderm. Lateral to it is the intermediate mesoderm, and this both of section, what you can see here, this is lateral plate or lateral plate mesoderm. This called somatic, the most medial part, and this is splanchnic layer of mesoderm. And the heart tube develops from the lateral plate of splanchnic mesoderm. Then this endoderm starts to secrete a lot of growth factors, which get to influence this splanchnic layer of mesoderm, as we talked about it before, to influence this splanchnic layer of mesoderm. And this growth factors stimulate the mesoderm to kind of differentiation or specializing. And when it differentiates, it will do 2 things. One, it forms the outer core and forms this inner core. as you can see. So then we will be, the outer portion will become the blood vessels and the heart tube. And we call this angioblast cells. And the inner portion, which will become the blood cells, called the hemoblasts or hemocytoblasts. So now let's take a look and see what growth factors influence the mesoderm in the next step. Now, from the lateral plate mesoderm, this actual chunk of mesoderm, this one, start to grow or fold, and it starts to specializing and form a little cavities, these cavities. And they start to and these cavities are called the heart tube, as you can see here. This is the heart tube and the pericardial cavities. Now what happens is this. In imagine these edges, these two edges, start to bring them closer, one closer to another. So when we do this, guess what happens? These heart tube are going to fuse, and pericardial cavities, when edges come together, are fused and makes one heart tube and one pericardial cavity. And now we have one more thing, is that the heart tube is hanging to the posterior wall. So some mesoderm connects the pericardial cavity to the heart tube through the dorsal mesoderm, which is this, the dorsal mesoderm or mesocardium. Now let's zoom in, and this animation, it's saying the same. We are forming this single heart tube with single pericardial cavity. All this information we explained on the figure before, so it's this slide summarizing what we have talked about. If we zoom in into the heart tube, so again, here is the pericardial cavity, and here is the dorsum pericardium. And when we look at the heart tube, it's made up of a couple of layers. The most inner is the endocardium, which comes from the mesoderm that's specialized to angioblast and give endothelial cells. So it's forming the endothelium. The outer layer is the myocardium, and it developed from the cardiac myocytes. And these cardiac myoblasts start to secreting like connective tissue or jelly-like substance, which forms between the endocardium and myocardium, which is the cardiac jelly. This is the endocardium and myocardium, and it's in between. Now we take a look at heart development from cross-section undergoing lateral folding. If we talk about the development of the heart tube in the pericardial cavity in sagittal view, as it will go under cranial folding. So if we take a look here, so here is the ectoderm. Again, this is the cranial folding. So this is the ectoderm and the endoderm, and in front is the cardiogenic area or clump of mesoderm. Sorry, which will become the heart tube. And here's the membrane which connects the cardiogenic mesoderm to the ectoderm and endoderm. It's called the oropharyngeal membrane. And again, this mesoderm undergo differentiation by the growth factors released from the endoderm and forming the heart tube and the pericardial cavity. The same process, we have it in cross-section. Now, the ectoderm end starts to folding. So the cranial end comes to the caudal end, and this will pull the tissue here more caudally, coming from the head to the neck area. As continues to keep folding, it completely goes to the chest cavity. Now, one more thing here, remember how the heart tube fuse and the pericardial cavity fuse, and the heart tube formed in the pericardial cavity. The same thing has to happen here, and this fold will pull the heart tube to sit in the pericardial cavity. And now if we take the heart tube from its cross-section view, we will take the same heart tube from the sagittal view. So this animation will make the picture more clear. As you can see, this is the cranial folding. The cranial end comes to the caudal end. As we are taking the horizontal and median plane. So this is the lateral folding compared to the cranial folding. So you can keep these two pictures of folding in your mind while we are going on. So now let's yank it out and look at it as a whole length. This is the top of the heart tube, and this is the bottom. At the top, this is basically going to be the outflow tract. So blood coming from the bottom and leave out from the top. These outflow tracts are the dorsal aorta. The dorsal aorta come from the area here called the aortic sac. This area here is called the Truncus Arteriosis. Below the Truncus Arteriosis is the bulbous cordus. Below the bulbous cordus is the primitive ventricle. And below the primitive ventricle is the primitive atria. And below the atria is the sinus phenosis. Let's dig in more and see what these structures become on. Top part goes into the dorsal aorta, and Truncus Arteriosis will go, this Truncus Arteriosis is what become pulmonary trunk and aortic arch. Then bulbous cordus, this becomes the right ventricle and right and left outflow tract. The next is the primitive ventricle, become left ventricle, and primitive atria become both left and right atrium. The last portion, the sinus phenosis. For the sinus phenosis, there is 3 inflow tracts. Maybe if it's clear for you. There is 3 inflow tracts entering into the sinus phenosis via the right horn. I'm looking for more clear picture. This is called right horn and left horn. So there are, as we said, 3 inflow tracts entering into the right sinus horn and left sinus horn. So, and these are the common cardiac vein, umbilical vein, and the most inner is the vitelline vein. As you can see, this is the vitelline vein. Now, this is not how the heart looks. So we will have a process called cardiac looping. And the first part is moving to the right and downward, and it continues to move down and to the right, but then the primitive ventricle, which is this, start to move towards the left, and the primitive atria is kind of coming to the back. So back here, we will have the primitive atria with the sinus phenosis, like this, and the inflow tracts. And then the primitive atria, as it moves backward and upward, it will pop off over the bulbous cordus and primitive ventricle, like in this picture. Now, this cardiac looping occurs as it's occurring inside the pericardial cavity. You can get more understanding of the lobing of the heart by this 3D animation. So these are the different parts after lobing occurred. So now let's focus on this sinus phenosis in this area, to move this area to start to lose some, this from inside, to lose some of the cells. And this area, it will move to the pericardial cavity, start to form around the heart, and this will give the visceral pericardium. One more thing, some of these cells of the sinus phenosis, it will penetrate into the heart and start to form some of the primitive conduction system. So this slide summarizes the steps of the cardiac loop process. Next step is the formation of Av canals. Now we have this heart tube again. There is actually a little sulcus between the primitive atria and primitive ventricle that is called the Av sulcus. This making section, so when we look at the inner aspect of the heart tube, this will be the posterior portion, and this is the anterior portion of the heart tube. And imagine that you are facing the primitive atria, and the primitive ventricles are inside. So there is some neural crest cells which will migrate into this area and forming a little area like cushions at the posterior and anterior portions, and it's called the endocardial cushions. As these cushions continue to grow, they fuse together and develop two little canals here and here, and this is called the septum intermedium. And this is the right Av canal, and this is the left Av canal. So this animation is illustrating the same principle of forming the endocardial or fusion of the endocardial cushion and forming two Av canal, the right and left. We will talk about the atrial septum formation later. So this is the same, this slide summarizing the tips again. If we see that in coronal section up to here is the primitive atria, and here is the primitive ventricle. And remember what is forming in septum intermedium, some of these endocardial cushion, as you can see here, it will form these valves and connect together by the annulus ring. From that annulus ring comes the valve flaps and form, from the flaps come the chordae tendineae, and this will become the tricuspid valve and the mitral valve. Now let's separate the atria. Coming down in the middle of this primitive atria, you're gonna find a little septum, almost comes all down to meet the septum intermedium. But it doesn't actually, reach it, or it's reaching up to the septum intermedium, but a little hole formed at the top of this septum primum. And this hole is called the it's called the septum primum, and this hole named ostium primum. But this septum primum continues to grow, and eventually it does reach the septum intermedium. Another hole develops towards the top, and it's called the ostium secundum. This one, ostium secundum. Another tissue here starts to grow and is called the septum secundum, which blocks the ostium secundum, which is formed by the ostium primum, which it's blocked and still a little space here, as you can see, between the septum secundum and the ostium secundum is called the foramen ovale. And eventually we have the right atrium and left atrium, right atrium and left atrium. So this is the septum primum. It's coming from upward to the endocard of septum intermedium. Then the septum secundum comes down. A little hole still here, which is the foramen ovale. Now let's separate the pulpus cordis and right ventricle. At the apex of the heart, some tissue starts to develop here, and that start to move upwards, which give the muscular portion of the interventricular septum. Then we still have a little space here between the septum intermedium and the interventricular septum, which will become it will grow down and separate the right ventricle and the left ventricle. So tissue moves downward and start to fuse with this muscular portion, and this is called the membranous portion of the interventricular septum. Eventually, we will have technically right ventricle and left ventricle. Remember, the pulpus cordis makes two things: right ventricle and outflow tract. So still we will talk about the other portion of pulpus cordis, but our portion now is the right ventricle. Now let's go or get some inflow tract coming to the right atrium. If we take another section here, we will have this veins entering into the left horn and right horn, as we explained before, which feeding into the sinus phenosis into the primitive atrium. Now what happened? All the left horn vein are breakdown and just have left horn, and the umbilical vein of the right horn will degenerate, and all that is left over feeding in the right horn is common cardial and vitelline vein. So the next thing is that the left horn starts to shift to the right and fuses with the right horn, and the sinus phenosis will get absorbed into the primitive atria. And when this happens, left horn will form the coronary sinus, and the common cardinal vein of the right horn will appear in the top and forming the SPC, and the vitelline vein forming the IVC, as you can appreciate it here. This is the left sinus, and this is the SPC and left SPC, the SPC and IVC. Finally, we will come, already we have talked about the fate of sinus phenosis. So the right horn will forms the smooth posterior part of the right atrium, and the left horn and body atrophy form the coronary sinus, while the left common cardinal vein forms the oblique vein of the left atrium. Finally, we will come to the pulpus cordis and truncus arteriosus and how they forming the outflow tract. Again, we have the coronal section of the heart already formed the right atrium, left atrium, and we have the LV and RV and Av canal. Now this portion of the RV is made by the pulpus cordis up and truncus arteriosus. Now I'm gonna take out from here to here, on this portion, from here to here, and explain it in more details. What happens in form to define the aorta and define the pulmonary trunk? So if we get a section here we will have this kind of structure here. At the top portion is the Truncus Arteriosis, and towards the bottom is the Bulbous Cordus. And again, we have neural crest cells that start to infiltrate on this area and start to form kind of ridges like this. At the bottom part of the bulbous cordus, you're gonna have bulbar ridges in the middle, but from anterior-posterior view, you will have ridges coming together. They are spiraling around this center axis. So this will form what we call it, this center, we call it the truncal. It's part of the bulbous cordus and called conus cordus. So these septum will fuse, and these edges coming together and will create septum here. And from this top to this top will create another septum, and another septum coming from the other side. So when we talk about the blood flow in these vessels, the blood flow, it will be in the back of the bulbar region, become under beneath the aortic pulmonary septum, and over the top going to the aortic arch. Then the blood flow into the anterior portion of the bottom of the bulbous cordus to move over the aortic pulmonary system and under the top portion of the aorticopulmonary septum and coming out from the pulmonary trunk. I think it's a little bit confusing, but by this animation, it will be more clear. How does it form and how the blood flow through the aorta and the pulmonary trunk? I'll reply it again. The last part is the formation of semilunar valves. It's formed by the same principle of the AV valves. It's the endocardial cushion that fuses together and forming the two valves or the semilunar valves. The last slide is showing the timeline of the embryo development, and this is the end of my talk. I hope it was clear. Any question or comment?
Thank you, sir. Very nice presentation. Well demonstrated. Illustrated.
Dr. Abdullah, any question?
Yes, excellent presentation as well. I was really impressed by all of these animations, and very, very, again, great capture of a detailed topic, and what's even more apropos is the ayat of the Quran that you started off with, during the break. It just leaves me personally in amazement and wonder as to how all of this occurs, and it just points to the ultimate power of Allah subhanahu wa ta'ala, greater. Having said that, I think there are some relevant processes in the development that, if they don't occur according to the usual, can result in certain heart defects that are seen, especially in the congenital world. And this is a question open to anyone over here. If you see on your, say, exams that there is a patient who is born with a complete AV canal or AV septal defect, maybe because Suha did this presentation, we can have her not answer, but maybe someone else, what do you think is the cause? And I think Sue had discussed this during her presentation. This is a board question that comes up, I know, in the American boards, but what kind of a defect in the development process results in an AV canal defect? So you have a timeline here. I'm sorry, I don't know all of the residents over here, so maybe I'll just pick someone at random. Let's see, Jumana Shabazz. Are you with us, or are you on mute? I don't think she has a microphone based on this. Okay, maybe Khalifa. Khalifa was with us several months ago. What an AV septal defect is associated with what defect in the development process? Are you with us, Khalifa? I think you're on mute. Khalifa Ali Nazi. Huh? Okay, I'm not sure that he is here with us. Abdullah Al-Huday. Can anyone hear me?
We can hear you, doctor.
Okay. Maybe Suha, since I'm not sure where.
You mean Dr. Abdullah, endocardial cushion?
Yes, correct. Endocardial cushion defect. Yes. So that's something to just be cognizant of. It's a question that comes up. The other things, and I don't think that you would find a question associated with this, but this is just a little bit of an anecdote. When I was a general surgery resident, I took a couple of years off and did research at Children's Hospital of Philadelphia, and there was a cardiology laboratory, and they were doing molecular. It was basically a molecular cardiology laboratory, and what they ended up doing in that laboratory, interestingly, during my time over there, was one of the postdocs was able to knock out a gene called, I believe, the TBX1 gene in a mouse, and just was able to then see the phenotype associated with this mouse. Interestingly, you consistently were able to get the Truncus Arteriosis defect. So that's where they this is at the University of Pennsylvania, and that's where they actually came up with the DeGeorge syndrome and the deletion or the mutation in the TBX1 gene as a contributing factor for Truncus Arteriosis. So we're still learning a lot about the molecular genetics associated with all of the signaling pathways and transcription factors, but it is indeed a fascinating domain. And one other question: when in the You know, the way Suha described that last animation, where she showed her last animation, where there was that spiraling of the truncus of the outflow tract partitioning. In fact, yes. So if you have a defect that associates with this process, what do you think can result?
Truncus Arteriosis.
Yes, that's one, correct. How about something else? How about if you have, so what is Truncus Arteriosis?
There is one common outflow.
Right, correct. One common outflow. And specifically, there is one, what below the outflow? One valve, one semilunar valve, whether it's tricuspid or whether it's quadricuspid. So what is another congenital defect that can occur where you have two semilunar valves, but you have a failure of, you know, the partitioning, septation between the artery?
Double outlet right ventricle, or even TGA.
No, we're talking about the septation of the great arteries. So we're talking about the outflow tract, and not the outflow tract. The great arteries is what we're talking about. You know, the animation that she showed right there above. So this, you know, spiraling. So along the lines of truncus arteriosis. But you are correct. You are correct. Is it Walid who answered?
Yeah.
Yes. Double out, right? Yes, that can occur. But when you have two semilunar valves, see where her arrow is? Where her arrow is. Imagine there's a defect right there.
Orthopulmonary window.
Yes, correct. The aortopulmonary window. Yes. Correct. And then I think Walid talked about looping of the ventricles, and that also ties into the looping process over here with respect to how the LV forms, morphologic LV forms on the left side, and the morphologic RV forms on the right side. And when you use the principle of your hand, the right hand is the one where you have the palm facing the septum, thumb facing the inflow, and the fingers facing the outflow. If that can be accomplished with your right hand into the morphologic right ventricle, that's D-looping. And if it's your left hand that does that in the right ventricle, then it's an L-looping situation. And the opposite of the looping in this process can result in L-looping. But any questions? Very nice presentations. Both of them were excellent presentations. Any questions from the group?
Thank you, Doctor. Appreciate your present and your comments. Jazakallah khair.
You're welcome. All right.
Any other questions or comments to Dr. Abdullah or me? I think by this we end our session today.
All right. Everyone have a wonderful weekend. Inshallah.
Inshallah. Thank you, Doctor. See you next week.
Thank
inshallah.
you. All right. Thank you.